with the explanations. If at all boring, please tell. Classification. A skin lesion can be classified in any one or more than one among this. It can be an infectious pathology like bacterial, fungal, or viral. It can be an infestation in the form of scabies or lice. It can be a papillosquamous lesion like psoriasis or lichen planus. It can be an eczematous lesion. There can be autoimmune skin disorders like connective tissue disorders like SLE, or a pigmentation disorder, or it can be hereditary. Other than that, we have only one major disease in the name of leprosy, other than all these. First, let us see one by one. In the case of bacterial, the very common condition that comes to our OP is pyoderma. Pyoderma is a very purulent infection of the skin because of streptococcal and staphylococcus. Smell is the characteristic feature. It can be primary and secondary. The primary, it can be non-follicular or follicular. Now, non-follicular pyodermal lesions because of streptococcus or staphylococcus are impetigo, ecthyma, cellulitis, erysipelas, and staphylococcal scalded skin syndrome. This is very rare. I have not seen even a single case of SSSS in my this short duration of practice. Impetigo, ecthyma, cellulitis, erysipelas. Out of this, impetigo is very common, ecthyma is very common, cellulitis is very common, and erysipelas is also not so uncommon. It comes to our OP, and as far as this follicular is considered, all these features are seen one or two in our OP. Definitely, folliculitis or furuncle or a carbuncle. Now let us see one by one. We will skip all this so that these are all classification side. We won't waste our time. Now comes impetigo and ecthyma. Both these are of similar presentation, and both these are due to a single causative factor. It can be streptococcal or staphylococcal, or it can be both. And an ulcerative form of impetigo is ecthyma. Ulcerative form of impetigo is ecthyma, where we can see this one. See how a bullous impetigo can form these features. There will be ruptured bullous lesion with a characteristic yellow crust will be there in this. We can see the children plucking those crusts out, yellowish crust out, and our participants had very clearly diagnosed one case of impetigo, of course. You can remember that photo also, and together with this, we can see this lesion also. It is very common in face and hands. And a similar sort of hand, foot, and mouth disease is also very common nowadays. Hand, foot, and mouth disease, they can be differentiated, but impetigo is a bacterial strepto or staphylo infection. Non-bullous impetigo can be seen in the clusters in the form of vesicles or pustules, and honey-colored crust is the characteristic diagnostic feature in the case of impetigo. This is ecthyma. You can see a deep layered skin involvement up to the dermis level, and it is scar forming once the lesion is healed. But impetigo is not at all scar forming. This is ending with the form of scar formation. See this erysipelas. This is a little bit severe condition to manage, and it has all the features of inflammation, and it appears on the face and also on the extremities, and it begins due to some other pathologies also as a secondary infection. This is the picture. You can see inflamed, and it's only because of streptococcal, and you can see the red hot rash seen on the lesions, and it will be painful. and always fever will definitely be there. Next is cellulitis. As we all know, we need not explain about it, but we can see the lesion. This is cellulitis. We have already seen 4 or 5 pictures from our OPD, and also the clear-cut features were also there. And this is, of course, this is from the textbooks or from internet, so that the pictures will be clear. For additional support, we had already discussed the lesion from our OPD cases. You can see those bullous lesions. You can see those red lesions. Now next comes follicular bacterial infections. Folliculitis, as the name suggests, this skin lesion, almost all the clinical conditions are named behind their region of effect part which is affected, and the pattern of the lesion and its chronicity. These are all the common factors behind naming in a skin disorder. So folliculitis is self-explanatory, where there will be pustules on the follicles, and it will be common in the fat-filled areas where there are plenty of hair. Furuncles or boils or bigger area of furuncles can be called carbuncles. Now see a carbuncle and a furuncle. One furuncle, multiple furuncles in a single area which is coalescing each other, which will form a bigger lesion called carbuncle. You can see folliculitis. Please remember that case which we discussed, which had psoriasis and later on turned into folliculitis. An abscess. You can see a small punctum on the face. This furuncle. All these are, by seeing itself, we feel like opening it, right? That's the, what to say, the picture suggests everything. It's highly, right now, the furuncle, ready to get the treatment. Highly painful, infective, bacterial. This is from internet. I have not seen a case, but it's very dangerous. It rarely comes to our hospitals, sort of. It's often seen in the neonates and children. It is generalized lesion, and all the features of infection and inflammation will be there. Necrotizing fasciitis is another group of condition, and this one is very common. Now we are having a case. I did not take the photograph of that because of ethical problem. I did not take photograph, but hidradenitis suppurativa is a sinus formed multiple ulceration on the flexures, axillae and perineal region especially. And it is usually affecting the apocrine glands, and multiple ulcers will be forming a tunnel or connections inside. The lesions may turn very nasty. There will be pus and infection, and other systemic features also will begin. And also rigors and chills will be there in the patient with fever. And one more significant and interesting finding in the recent studies is low levels of vitamin D in the cases of hidradenitis suppurativa. And the condition is usually associated with a triad. Triad is 3 clinical conditions associated together in the form of acne conglobata, perifolliculitis, and intertrigo. Intertrigo, we had a photo. Now comes viral skin infections in the form of molluscum contagiosum. Molluscum contagiosum is a yellow, small, multiple vesicles or pustules which has creamy secretion in it. A creamy secretion in it, a cheesy material in it, which is 2 to 5 millimeters in diameter in the linear pattern, just as we see in the case of Keebner phenomenon. Just like that. And it is usually seen in the face and hands. And one more thing is, it is usually seen in children, of course. if it is seen in adults and if it is seen in genitals, we have to do the ELISA, or we have to definitely rule out sexually transmitted disease that is usually associated in adults with the molluscum contagiosum on the genitals, and it spreads from skin to skin contact. That is why it's very common in children. They go to classroom when they see and check one another and they come in contact with that, the other one also will get. Next comes herpes simplex. We all have seen the cases also. HSV1 and HSV2 are the two variants. One is above the waistline, two is on the genitals, and two is because of sexual contact, and one is usually contagious, and they are usually associated with all the inflammatory features of genital and mucous areas. Even though the condition is very much waxing and waning in its nature, it has a very much recurrent history, and it has a few exacerbating factors in the female in the form of menstruation and also emotional stress. So HSV2 can be diagnosed clinically itself. For confirmation, we can send the patient for laboratory investigation for HSV directly. Herpes zoster, Visarpa we call, but it's not only Visarpa, much more than that in the diagnosis. We will discuss when we discuss about the medicines. And it is due to the varicella virus. We have seen the photographs, 2 or 3 photographs we had seen which were from our OP. And its incubation period is usually 14 to 21 days. And then it spreads. And it depends upon the dermatome affected. If it affects on the nerves which are related to the eyes and nose, there are all the chances of losing those organs. If it occurs on the ophthalmic branch of trigeminal nerve, there are all the chances of losing the eyesight. If it affects the olfactory, there can be a chance of losing of smell perception. And if it is on the sacral plexus, we can find the urine retention, and also there can be a possibility of muscle paralysis if other plexus are involved. But the condition is very painful, and it has the similar virus variant of chickenpox. So herpes zoster and chickenpox are interrelated, and a previous history of chickenpox can later lead to herpes zoster because the virus remains dormant in the root ganglions, especially in the spinal canal. So herpetic neuralgia is a very common presentation if it occurs in the elderly. Measles, now very rare. It's very, very rare now. Cases are usually, not as frequent as it used to be a few years before. And it's due to paramyxovirus, and it is very common in children. But one thing is very dangerous is it usually leads to pneumonia and encephalitis, that we have to be very careful, and we should not allow the cases to go for secondary complications like pneumonia and encephalitis. And the identifying feature is fever, headache, body ache, cold, sore throat, and running nose. Out of these, 3 or 4 features will be seen for sure. And the child will usually develop the lesion on the face or on the trunk. Now that is decided. Then we have to be very careful. We can manage it very beautifully, but only thing is that we should not allow the child to go for the further stage like pneumonia or encephalitis. Next comes chickenpox, highly contagious in any age, is said to have immunity once it develops. So it won't recur. And one remarkable thing is it is self-diagnosable. We need not depend on the other medical consultation. So children usually are diagnosed by their parents itself, and they will call, or those who are too ignorant about it will come to the OP, and then there are all the chances of getting it spread all over. and it's a varicella related condition, and itching vesicles, which later turns into a pustule, then it forms a crust, then a scab formation, it will get shed off, and there will be mild scar. This is the series of presentation of chickenpox. And usually 14 to 16 days of incubation period is there, with a range of, it can go even lesser, like 10 days, or it can extend up to 21 days. But on an average, 14 to 16 days is the period of incubation. See, what is a viral condition? It spreads, and chickenpox and zoster. Dermatomes are affected. Painful lesion. Now comes fungal infection, which are due to dermatophytes, fungi. Tinea is the common name which we give. Itching, swelling, blisters, and severe scale formation will be there in this. These are the characteristic feature of a chronic serious infection. But in very milder cases, there will be a little bit of itching with the irritation and swelling. So it depends upon the body parts. If it affects on the head, it is called tinea capitis. Why I told this? First, because tinea capitis is considered to be highly spreading from the barber shop in the OP, which can later lead to alopecia areata or totalis or universalis. So we have to be very careful while dealing with tinea capitis. Better not to touch the lesion with bare hands. And next comes tinea corporis, which is seen all over the body. Tinea lesions, we already have seen the photographs, and ringworm we usually call. And if it occurs on the legs, it is called tinea pedis. And we have another condition called intertrigo, which affects in between the fingers of the hand or foot, and tinea cruris, which occurs on the groin and upper thigh region. The common features are, it is highly itching or pruritic, it is circular, well-defined patches which are erythematous and scaly. Its middle area, central area will be clear, but the margins will be active. You can see the various presentations of tinea. Now that is not a case of lichenified or hyperkeratosis or psoriatic lesion. It's a case of fungus. And onychomycosis is another feature. Onychomycosis or tinea unguum, which occurs to the nails. Tinea versicolor, white patches. And another one is tinea rosacea. I will show the photo. Next, pediculosis or lice, body lice. We just need to observation, just to the findings are very self-explanatory. We won't go in detail. Scabies is to be seen seriously. It's very contagious, which occurs in children. Come to OP, so better not to touch it directly, because skin-to-skin contact is the commonest mode of spread. There will be burrows into the skin, and it usually affects on the groin and on the folds, on the fingers, toes, or beneath the breast in females. And the Sarcoptes parasite lays the eggs, and then its life cycle is completed in that single lesion. That is why it recurs. This is the photograph, and that is a photograph of Sarcoptes. So let us skip this slide. Now let us go towards psoriasis. In between that, organizers, I have a small question. Whether psoriasis and lichen planus will be dealt separately by some other doctors? Organizers?
Yes, sir. I will get back to you on this.
If at all psoriasis is there, because this is the biggest area for a dermatologist.
Yes,
I will skip now. I will go to the next disease.
Okay. Sure, sir.
Information, I will come back to this slide.
Sure, sir.
These are the photographs of psoriasis. You can see Keebner's phenomenon. The middle part of our pictures, the second photo, there is a linear marking. It's called Keebner phenomenon. And this is a plaque psoriasis. The lady who is holding her palm and foot is plantopalmar psoriasis. Plantopalmar psoriasis. The next one was guttate psoriasis, which is on the trunk. Guttate psoriasis. The next one is pustular psoriasis. The psoriatic lesions of the nails. Psoriatic lesions of the nails. This is onychomycosis. And inverse psoriasis, that is flexural psoriasis. Usually the psoriasis is seen on the extensor surface, and very rarely it is seen on the flexure surface. You can see on his axilla, there is a psoriatic lesion. It's not a fungal lesion. Why this photo is deliberately put? Because we usually tend to confuse this fungal lesion because of the site. And this is actually inverse or flexural psoriasis. We have to depend upon the proper clinical examination and go for the diagnosis and then management. The next two photos of the fingers are psoriatic arthropathy. Lichen planus. See the photographs of lichen planus. One thing is, it's self-limiting. Lichen planus is a self-limiting condition. So we need not bother too much about it until and unless it causes a lot of disturbance in the form of itching and a cosmetic value. Then we can treat it. We can cure it very easily by giving a proper Ayurvedic management. This is a common site of pityriasis rosea. Commonly, people get confused with guttate psoriasis and pityriasis rosea. Now, all the confusion should go off. You can see the lesion, red, raised patches, not lichenified, purplish, or there are any greasy appearance of that lesion. Linear markings are also not seen. PRP. PRP is very common condition. Pityriasis rubra pilaris. These are the features. Now, erythroderma. Any skin condition can lead to erythroderma. It's an infective condition which goes to the second level of eczema, psoriasis drugs because of any adverse drug reaction, or a case of pemphigus, or a pemphigoid, or a lichen planus. Second level of infection. We had seen 3 pictures of a person who was in his pant with with 3 pictures, if you remember our clinical picture. This is footwear dermatitis, already we had discussed about. Now this area is important, which is due to exogenous or contact eczema or contact eczema, contact dermatitis, and endogenous are usually atopic. So which comes to our OP is either due to some external factors like watch, ornaments, shoes, dyes, or dress. Some other external factor should be involved in a case to be diagnosed as due to exogenous in origin. Next comes endogenous eczema, where the internal factors are the reason behind those eczema. The classical case is atopic dermatitis and seborrheic dermatitis. Discoid eczema is, of course, we will have a photograph we had in our OP, and Pompholyx is very rare diagnosis. We had received 1 or 2 cases. We need not discuss too much about it, but atopic, seborrheic, and discoid are to be seen. Now let us see how an exogenous origin eczema is seen. It's a non-allergic reaction that results from exposure to an irritating agent. We already discussed the causative factors like soap, chappal, dress, watches, ornaments, dyes, so on. And they usually, why it gets repeated? Because they have memory cells. Once the primary exposure is there, and we can see all the features like exfoliation, oozing, ulceration, and a definite history of contact. Once we cure the case, there will be memory cells recorded in the brain. So what happens is, whenever a similar exposure occurs in the later part of our life, the brain will again trigger. It will make remember to our immune system that the same infective factor has affected again. So start the reactionary features. That is the basic reason behind such allergic manifestation developing frequently. Next is allergic contact dermatitis. Now this is a little bit different pathology because there is an involvement of type 4 hypersensitivity reaction. Type 4 is a delayed response and it's very difficult to cure. And definitely we have to look upon the factors, immunoglobulin factors like IgE and IgA. The presentations will be very similar. There won't be any change in the presentation. All those features of eczema will be there. Only difference will be in the laboratory findings where we have to see IgE and IgA and absolute eosinophil count and make sure there is no autoimmunity in it. Next is atopic dermatitis. It's a chronic, relapsing, itching clinical condition seen in infants and children and usually related to a hereditary or immunological factor. There are 3 phases for atopy. One is infantile, which occurs even days after birth, and it can occur in childhood because of a chronic respiratory infection, and it can occur in adult because of a chronic respiratory infection of childhood. So these can also be the triggering factors behind the manifestation of atopic dermatitis in the later phases, like in the childhood or adult. And all the features are similar. Here also, the IgE levels will be very high. And today we had seen a case of IgE level more than 10,000. It's usually 100 or 85 to 100 is the common reference value for IgE. We can even get the cases up to 10,000. In such cases, we have to deal very carefully because usually the children or young adults will have a respiratory pathology also associated with the skin clinical condition. These are the common sites of eczema and atopic dermatitis. This is the feature called lichenification. In Ayurveda, we call it charmakhya. Seborrheic dermatitis we have already discussed while discussing about the photo itself. Nummular or discoid eczema, where there will be the features of eczema itself, but the site will be different. It will be on the extensor surface of extremities and very common in the later part of the age, and the lesions will be coin-like, discoid. Now comes vesiculobullous lesions. These much are the lesions that we confront in the textbook, but we confront in the clinics commonly with the pemphigus, bullous pemphigoid, and erythema multiforme. These are the features that usually comes to our OP, and dermatitis herpetiformis is very rare, and the other conditions like Stevens-Johnson syndromes are very dangerous. Usually they won't come for our management, maybe because of its very acute nature. This is pemphigus. It's a flaccid bulla of various size, and these bullae arise from the healthy skin all of a sudden, and they leave a crust with the skin denudation, and any epithelial tissues will be affected. But there is always a beginning. There is always a beginning, and it is usually associated with ADRs. Drug reactions are very, very potent cause for the manifestation of pemphigus. So once we see such lesion, we have to get the investigations done very seriously considerable case. Pigmentation disorders like vitiligo and leukoderma, we will deal tomorrow. Systemic illness, we won't explain it today. And pemphigoid is not so dangerous clinical condition. Today also one case got admitted with pemphigoid, repeated. Beautifully we can manage with Ayurveda. Very, very nicely we can manage with Ayurveda. These are the two classifications or variants of pemphigoid, where one is bullous variety, other is benign mucosal pemphigoid. So the features are explained, and one characteristic difference is this benign mucosal pemphigoid has erythema, ulceration, and desquamation of esophageal area. Oral and esophagus are usually involved in this, but in the bullous form, it is usually on the trunk. Urticaria, as you all know, type 1 hypersensitivity reaction. Beels are very common, and IgE levels are to be checked, and we have to evaluate the case properly, because once there is a release of histamines or mast cells, there are all the chances of the patients at times getting laryngeal spasm. So such severe cases we have to deal in the form of emergency. Other things we can very well manage by Ayurveda. Now comes leprosy. Leprosy, as we all know, the master of all skin conditions, and the diagnosis itself is very, very characteristic in this. We should never ever fail to diagnose this clinical condition or get mistaken by the diagnosis like pityriasis versicolor or a fungal infection. The classic clinical diagnosis is loss of sensation or lack of sensation on those areas in the hypopigmented area, and ulnar nerve should never be missed. Ulnar nerve should never be missed. There will be thickening of ulnar nerve, and these features should never be missed. Let me please remind you one case which came to my OP, where she was a girl of 20 years, and she had come to my OP for hair fall, and once I just had to check whether there was any involvement of scaling on the hair, dandruff, but she told there are a little bit of scales on the skin. And then what happened is I observed a small white patch like this senior lady on her scapular region, and I just examined. There was a little bit lack of sensation on that area, and for her or my luck, immediately I sent that case to the dermatologist and referred to my sir. Especially I had a small clinical experience during my BMS days under a dermatologist in Udupi, and I sent to sir, and sir exactly diagnosed this to as lepromatous borderline tuberculoid leprosy. So we managed with the this allopathic manager. I referred case to sir, and then they were so happy that if it was kept unnoticed, it would have been taken some other bad turn, right? And another case was there where the patient had come with the cervical spondylosis. That was during my teaching period in Udupi. She had come with the cervical spondylosis, and she was treated with the Alepa, a Pedanalepa, during the first course of management for her CS. On the 7th day of Alepa, the patient had loss of sensation all over the upper limb. All over the upper limb. The total upper limb was numb. No 2-point discrimination. Sensory loss was there, and the case became a neurological one. So we were afraid whether there was any adverse reaction or some medical complication was there, and we sent to Manipal with the consent of our HOD, and then they saw the case, and they diagnosed it as lepromatous leprosy. So what happens is there was a few masking of features at times, and it was an accidental finding, and she was treated in modern management, and we got the relief. I will show you a few pictures. Please note these pictures. These are all indications of leprosy. See the face, eyes, nose, and his cheeks, fingers. Ulnar nerve should never be missed. The palsy. So with this, I conclude my session. I hope I am